Menstruation is a natural part of life for most women. Every month, the uterus sheds its lining, resulting in a period. Many women endure menstrual pain, also known as dysmenorrhea. Up to 90% of women experience some degree of menstrual pain. Pain can range from mild cramping to severe, debilitating pain. It's typically felt in the lower abdomen and can radiate to the back and thighs. The good news is that most menstrual pain is treatable. If you're concerned about your menstrual pain, talk to your doctor. Dysmenorrhea is broadly classified into two categories, primary and secondary. Primary dysmenorrhea is the most common type and refers to pain that is not caused by any underlying medical condition. It typically starts a few years after a girl begins menstruating and may improve with age or after childbirth. Secondary dysmenorrhea, on the other hand, is caused by an underlying medical condition affecting the reproductive organs. This condition could be endometriosis, fibroids, pelvic inflammatory disease, or adenomyosis. Secondary dysmenorrhea often develops later in life and may worsen over time. It's important to distinguish between primary and secondary dysmenorrhea because the treatment approaches differ. While over-the-counter pain relievers and home remedies often suffice for primary dysmenorrhea, managing secondary dysmenorrhea requires addressing the underlying medical condition. The pain associated with primary dysmenorrhea is primarily caused by prostaglandins. Prostaglandins are hormone-like substances that the uterus produces to contract and shed its lining during menstruation. These contractions are what cause the cramping sensation. The amount of prostaglandins produced varies from woman to woman, which explains why some experience more severe pain than others. Typically, the pain starts a day or two before the period begins and lasts for 2 to 3 days. It usually peaks when the menstrual flow is heaviest. While prostaglandins are essential for menstruation, excessive levels can lead to intense pain and discomfort. Thankfully, several medications effectively block prostaglandin production or action, providing relief from primary dysmenorrhea. Unlike primary menstrual pain, secondary menstrual pain results from an underlying medical condition affecting the reproductive organs. These conditions can cause structural abnormalities, inflammation, or other issues that lead to painful periods. Some common culprits include endometriosis, adenomyosis, uterine fibroids, and pelvic inflammatory disease. Endometriosis occurs when tissue similar to the uterine lining grows outside the uterus, often on the ovaries, fallopian tubes, or other pelvic organs. These endometrial implants respond to hormonal changes during the menstrual cycle, causing inflammation, pain, and scar tissue formation. Adenomyosis, another common cause of secondary menstrual pain, occurs when the uterine lining grows into the muscular wall of the uterus. This condition can cause heavy, painful periods as well as pelvic pain and pressure. Section 5. Endometriosis, a common culprit. Endometriosis is a common gynecological condition affecting an estimated 10% of women worldwide. It occurs when tissue similar to the lining of the uterus, called endometrium, grows outside the uterus. This tissue can implant itself on the ovaries, fallopian tubes, bladder, bowels, and other organs in the pelvic cavity. Like the lining of the uterus, endometrial implants respond to hormonal changes during the menstrual cycle. They thicken, break down, and bleed. But unlike the uterine lining, the blood and tissue shed from these implants have nowhere to go. This can lead to inflammation, pain, scar tissue formation, and in some cases, infertility. The pain associated with endometriosis can be debilitating and often extends beyond menstruation. Women with endometriosis may experience pain during intercourse, bowel movements, or urination. The exact cause of endometriosis is unknown, but various theories suggest retrograde menstruation, genetic predisposition, and immune system dysfunction as contributing factors. Section 6. Adenomyosis. When the uterus lining goes astray. Adenomyosis is a condition that can cause secondary dysmenorrhea. It occurs when the endometrium grows into the myometrium, the muscular wall of the uterus. This can cause the uterus to enlarge and become tender, leading to painful and heavy periods. The exact cause is not fully understood, but may be related to hormonal changes or previous uterine surgery. Symptoms include heavy menstrual bleeding, severe cramps, pain during intercourse, and chronic pelvic pain. Section 7. Diagnosing the root cause of menstrual pain. Diagnosing the underlying cause of secondary dysmenorrhea can be challenging as symptoms often overlap with other conditions. A thorough medical history, including the nature, duration, and timing of pain, is crucial for guiding the diagnostic process. A pelvic exam is usually the first step in evaluating menstrual pain. This exam allows the doctor to check for any abnormalities in the reproductive organs. Imaging tests such as ultrasound, MRI, or CT scan may be recommended to get a clearer picture of the uterus, ovaries, and surrounding tissues. Laparoscopy, a minimally invasive surgical procedure, is considered the gold standard for diagnosing endometriosis. During laparoscopy, a thin, lighted tube with a camera attached is inserted through a small incision in the abdomen. This allows the doctor to visualize the pelvic organs and look for any signs of endometriosis. Section 8. Treatment options, finding relief. The treatment for menstrual pain depends on the type of dysmenorrhea, the severity of symptoms, and the underlying cause. For primary dysmenorrhea, simple lifestyle modifications and over-the-counter pain relievers are often sufficient to manage the pain. However, secondary dysmenorrhea usually requires addressing the underlying medical condition in addition to pain management. Medications such as non-steroidal anti-inflammatory drugs or NSAIDs are commonly used to relieve menstrual cramps. These medications work by reducing inflammation and blocking the production of prostaglandins. Hormonal birth control methods, such as birth control pills, patches, or vaginal rings, can also be effective in reducing menstrual pain. These methods work by preventing ovulation and thinning the uterine lining, resulting in lighter and less painful periods. Section 9. Medications for pain management. Over-the-counter pain relievers, particularly non-steroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen and naproxen, are often the first line of treatment for menstrual cramps. These medications work by inhibiting the production of prostaglandins, the hormone-like substances responsible for uterine contractions and pain. For more severe pain, a doctor may prescribe stronger pain relievers or recommend a short course of prescription-strength NSAIDs. In some cases, a doctor may prescribe muscle relaxants to help relieve muscle spasms in the uterus. If over-the-counter and prescription pain relievers are not effective, a doctor may consider other pain management options, such as nerve pain medication or antidepressants, which can have pain-relieving effects at lower doses. It's important to note that all medications should be taken as directed by a healthcare professional. Section 10. Hormonal birth control, regulating the cycle. Hormonal birth control methods, such as birth control pills, patches, or vaginal rings, can be highly effective in reducing menstrual pain, especially for women with primary dysmenorrhea. These methods work by preventing ovulation, the release of an egg from the ovary. By preventing ovulation, hormonal birth control methods reduce the production of prostaglandins, the substances that cause uterine contractions and cramps. They also thin the uterine lining, resulting in lighter periods and less menstrual flow. Hormonal birth control methods can also help regulate irregular periods, reduce heavy bleeding, and improve other menstrual-related symptoms, such as acne and mood swings. However, it's important to discuss the potential risks and side effects of hormonal birth control with a doctor before starting any method. Section 11. Surgical interventions, a last resort. Surgery is typically considered a last resort for treating menstrual pain and is usually reserved for cases of secondary dysmenorrhea, where the underlying condition does not respond to conservative treatments. The type of surgery recommended depends on the specific condition and its severity. For endometriosis, surgery may involve laparoscopically removing or destroying endometrial implants. This can help reduce pain and improve fertility. However, endometriosis can recur after surgery, so hormonal therapy may be recommended to manage symptoms and prevent recurrence. In severe cases of adenomyosis where other treatments have failed, a hysterectomy, the surgical removal of the uterus, may be an option. However, this is a major surgery with potential risks and complications and should only be considered after careful evaluation and discussion with a doctor. Remember to consult your gynecologist for personalized treatment. Like, share, and subscribe for more informative content.